Good evening and welcome to our next webinar for the James Clinic. Tonight we are going to talk about high cholesterol and a life without statins. I am in my newly redesigned office, so I hope you enjoy that. This is going to be an open discussion, so if you have questions as we go, feel free to drop them in the chat. While I have the presentation up, I can't see those comments, so as soon as I close those, we will get to them. So here we go. We are going to dive in, and just like everything else we do here at James Clinic, we are looking to set the record straight of information that's been passed along for far too long, that's incorrect. So here we go. I'm going to share my screen. We have a nice patient example tonight as well. So, um, um, and this is the part I always need help with. Um, okay. So as we look at this, is cholesterol really the villain? We're going to talk about what is cholesterol. Is there a link between cholesterol and heart disease, which is basically what we've been told since the beginning of time, is that if you eat a steak, you're going to have a coronary artery disease, you're going to have a heart attack, and these two things are intimately interconnected. What is a statin? What is this class of medications? We have so many people who now come into our office and say, I don't want a statin. And it's where our conversation is just shut down before we even get started because they do have a bad rap, and maybe deservedly so, but we'll kind of talk about what are they, what do they do, and are they actually ever helpful? Is there ever a clinical role for things? We're going to go over the James Clinic integrative approach to lipids and reducing your cardiac risk, and what do we actually look at? So some of those things should be a bit surprising. And then, of course, our open discussion, we're always going to get into that. Tonight's talk is full of pictures. So as you can see here, we're going to be using this terminology. So I'm just going to point this out as we get started. So HDL is high density lipoproteins. This is, quote, the good cholesterol. As you can see, it's small. So if you think of that as a garbage truck, what it's going to do is go through your arteries, pick up the junk and bring it back to the liver, as opposed to the LDL, which is actually going to bring cholesterol out into the periphery and the circulation. As it gets higher, small LDL, we get to bigger LDL. We're going to talk about which one of those is better. There's something called LP little a down here that we're going to talk about as well, that is often overlooked in the assessments. So we're gonna get into all of this terminology. So what is cholesterol actually? These are lipid molecules that have many functions in the body. And one of those, first of all, it formulates 25% of the brain. So whenever we come in very well intentioned to reduce this risk because we want to get rid of heart disease, one of the patterns you're going to see is a lot of side effects in the brain with things like cognition, memory, personality, and mood, as well as an increased risk of dementia long-term if we reduce that too far. So we'll kind of talk about the balance between those two priorities as we go. It incorporates into the cell membrane. So if you can see down here, cholesterol basically becomes part of our cell wall or our cell lining. So this is why we supplement with things like omega-3 fatty acids, because we want good fats, we want cholesterol in the lipid membrane. We want our cells to be nice and fluid like a jellyfish, not stiff with those trans fats that we get from processed foods and processed oils. So that's one of the things it does. It's part of the communication of our cells between what's coming in and what's going out. One of the other things that's really critical that it does is it's the building block of hormones. So if you can see here, this is the hormone cascade. Cholesterol is number one, is the building block. It turns into pregnenolone if you go this way. This one's a little bit harder to see, but it does become progesterone. It comes androstenedione, testosterone, it becomes testosterone. So here's your androgen pathway. And then over here is your estrogen pathway. Here's your aldosterone. So this is your kidney, the hormones that have to do with your kidney and excreting things through the kidneys. And then these are your estrogens. So think about this as a plinko board or a waterfall. If you have less coming in, you have less distributing to all of these things. Not shocking, when we reduce the cholesterol too far, what we start to see are symptoms of hormone imbalance in people, androgen deprivation or androgen deficiencies, um, menopausal symptoms getting worse, and things like that. The other thing that it is an opsonin. So this is actually part of the immune system that tags a bad guy so that it can be swallowed up by the immune system. So one of the things we need to keep in mind, and often forgotten, is that elevated LDL actually might be a clue that we're dealing with some kind of an occult infection, and that needs to be explored before we just smash it down and forget about the consequences. So it's really an important signal in the body, and something that we need to be watching and considering more things for. So when we look at a standard lipid panel is going to have four parameters: total cholesterol, which that we've been told, that used to be 300 to 400 was the normal. Now we're told it needs to be under 200. So eggs are bad because they're high in cholesterol, remember. The HDL is that good cholesterol that we talked about. That's the healthy cholesterol that's going to help clean up the arteries and bring things back to the liver. LDL is, quote, the bad cholesterol, and it's become the villain or the bad guy. And then we have triglycerides, which you don't hear about very often. So those are the four components of a basic lipid panel. When you come to a clinic like ours, we're going to do something called an advanced lipid panel. So one of the really important things we need to keep in mind is, what is LDL? So LDL, or that bad cholesterol, when you're given a number like 100, which is, quote, the goal, this is a weight. So if we pulled the cholesterol out of your arteries and we put it on a scale, this is how much it weighs. So if you can see here, big, healthy, fluffy cholesterol can have the same weight as more tiny, dysfunctional cholesterol. So if you think of this as a spectrum, big, fluffy, healthy cholesterol, we think of like a tennis ball, and it slowly bounces through the arteries. It can't really cause any damage because it's moving so slowly and it's so big. The liquid of the plasma and the flow makes it so it can't damage the lining of the arteries. Now, think about these small dysfunctional. So, as we develop metabolic syndrome and those LDLs shrink down and they become more like marbles, those marbles are now pinging around like a pinball machine, or a marble in there. They're going at higher rates and they find cracks in the arteries. And since they're so small, they actually burrow themselves or embed in the lining, in the cracks in the arteries, and start that atherosclerosis process. So, this is why having a total LDL or just a basic lipid panel is not the whole story. You have to know the particle number and the particle size to get a better idea of what's going on. And this is a graphic where you can see 125 LDL means different things for different people. So if it's nice and big and fluffy and healthy, you have a very low risk of heart disease. But as it becomes smaller and more dysfunctional, you're sliding your way down this metabolic into cardiac risk zone, because embedding into the damage, that is really starting the inflammatory process in the walls of the arteries, which is where we get things like heart attacks. And here's a visual representation of what that is doing. There's also something called the glycocalyx. I'm just going to blow this up so we can see it a little bit better here. So we have something like seagrass, which is the lining of the inside of the arteries. And basically, as blood flows past it, it sways like grass, and that measures the rate of blood flow, and it sends hormonal signals to the inside lining of the arteries. For example, if the blood is flowing fast, it sends a signal to vasodilate because that slows the rate of blood flow. Versus if there's a narrowing, kind of like in a hose, the blood travels faster through those areas. So we want nice, healthy glycocalyx. And an interesting fact on this, and a little tidbit, is that people who take glucosamine chondroitin have a 50% reduction in heart attacks. That's one to write down, because that supports the endothelial glycocalyx. This got shaved off during COVID, cut off completely. This is a lot of the endothelial damage that came from COVID. So you can see here, this is your healthy endothelial layer. We get those small, tiny little marble LDLs, and they start to ping into the walls and they burrow in, and that starts that inflammatory process. Now we have an autoimmune process. Now our entire immune system inflammatory process is activated. That begins to narrow the lumen of the artery, And then, as we know, what happens is heart attacks are from a rupture of that plaque, sending platelets, and then it causes complete obstruction and a heart attack. So that's what coronary artery disease really is and what causes it. So it's more when we talk about things like high blood pressure, this is more of an autoimmune condition of the arteries as opposed to just a symptom that we smash. We need to think of it more comprehensively as we're looking at reducing risk. So along came the statins. So around 1996, this class of drug has been in the pipeline for about 20 years, and they knew it wasn't going to go anywhere. But this is a class of drug that blocks cholesterol formulation down the mevalonate pathway. So if you start with acetyl-CoA, if you know your Krebs cycle, that's the starting of this process. You give statins, and it inhibits HMG-CoA reductase. That's the class of drugs that they are. And that blocks cholesterol synthesis. But look what else it blocks: CoQ10 production. CoQ10 is very essential for our mitochondrial function, or for the powerhouse, the batteries in the cells to make energy. So basically, by giving statins, we're poisoning our own little powerhouses in each cell. And if you think of people with the most severe issues, it's generally a mitochondrial dysfunction problem as opposed to a cholesterol problem or something more macro. It is an anti-inflammatory drug. It's been studied for that for a long time. So there's a lot of argument that it helps stabilize the plaques in the arteries. It lowers LDL somewhere in the neighborhood of 20 to 30%. And again, stabilizes plaques. However, the myth has been that it reduces mortality from cardiovascular disease. Because despite widespread use of statins, this is now a $10 billion industry per year. We have not yet reduced cardiac mortality from this. So what are the recommendations around statins? So they started out as secondary prevention. So when you have a heart attack, you're going to be given a statin drug in the hospital to prevent having a recurrence of the heart attack, secondary prevention. There is absolutely no data that reducing LDL works as primary prevention. But when you look at the American Heart Association and the American College of Cardiologists and all of their guidelines, here's what it boils down to. If you're over 40, you need to be on a statin. That is so bogus. It is such a bad guideline and recommendation. And this is one of the pivotal wrong pieces of information that has been parlayed into our medical system. This is Medicare outcome guidelines. This is diabetes outcome guidelines. This is embedded in every facet of what we do. So even if you're kind of a more rogue clinic like us, when I see a patient who has high cholesterol, I still have to counsel them that statins is the standard of care. And we have to talk through that risk. And I have to document that I offered a statin, even if we're saying we're not going to do it. I have to medical legally document that, which is, again, part of the problem in our system on a larger scale. So if we look at statin use by year from 2015 to 2021, we saw a huge uptick in that, over 30%. But starting back in 2008, 2009, we see it rising even higher. So as these guidelines are implemented, they're part of the pay for performance for physicians. So when you're looking at quality indicators for hospitals, if they don't have a certain percentage of people on statin drugs, like after admission for heart attack, after admission for open heart surgery, after admission for diabetes, these are the quality indicators they're looking for. And the hospitals either earn more money by having people on statins, or they're financially penalized for not meeting that quality indicator. You're also seeing this in some of the primary care physician offices. Their charts are audited for these types of endpoints, and it's not the endpoint of how is the patient doing, it's the endpoint of are they on the drug we want them to be on. So another important thing that you need to know about statins, and this is again why it's getting a bad rap, there's about a 10 to 12 increase in diabetes. But wait, we're supposed to prescribe this for diabetic patients to lower their risk, but it increases the chance of them having diabetes. So it's kind of a catch-22. One of the bigger concerns that I have is there's absolute loss of muscle strength. So you're looking at about 10 to 15% per year loss in their strength. So if you think about somebody in their 40s, they're still going to be able to perform, not a problem. But if we are looking at somebody who's closer to their 80s, where getting like standing up out of a chair is a major task for them, you take away 10 to 15% of their strength, you now have a person who goes from independent to dependent and they're not able to live at home alone. So again, huge impact from a basic recommendation that's been, pushed for no reason. Some other interesting caveats to statins: 50% of people dropped out of clinical trials due to side effects. So this is hard to find. This is a hard data point to nail down because basically the patients fall out of the studies and they start with a new denominator of the people who didn't fall out. So some of the things that you commonly see after starting a statin are going to be muscle and joint pain, fatigue. Those are the big three. But in more and more, I've been reading about cognitive issues, memory issues, mood issues, because some of these drugs get through the blood-brain barrier and change cholesterol metabolism in our brains. And one of the things that's really developing is if you think about Alzheimer's dementia, one of the most feared illnesses of all of these, we are seeing massive increases in dementia. And when you look at how that correlates with LDL numbers, if you get your LDL numbers down below 70, where the cardiologists want it as their end goal, you are losing mentation. You are losing that cognitive ability. So huge side effect that we're very concerned with when I see people come in. And it is maybe twice a month I see someone who comes in on a statin where their LDL is 50. So we're pulling them off of those and rechecking in 3 months to make sure they don't fly too high. But 50 is way too low. I like them. I would prefer they'd be somewhere 90 to 110, 120 if I could pick. Now, if you're 50 on your own, you're 50 on your own, but we don't want to drive it low with medication. One of the other caveats is that I have patients coming in who've done coronary calcium scoring. So they go in, they get a CT scan of their heart, looking at their coronary arteries. And what they find is these arteries are calcified. So we're looking for blockages, trying to stratify risk of having a coronary event. And so what happens? You go in and you have a calcified artery, you're put on a statin. Guess what statins cause? Calcified arteries. So wrong treatment, wrong application, wrong disease process, incomplete assessment, because a lot of these doctors are not looking at the LDLP and triglycerides and fasting insulin levels and the things that we're going to look at from a functional perspective. So who gets heart disease? This to me is fascinating and got my attention when I first was introduced to functional medicine, because again, I'm kind of the caveman, the knuckle dragger of the medical world. I'm a general surgeon, we have opposable thumbs. I had to look up what is a cholesterol level, what is a normal cholesterol level when I started doing this 10 or 12 years ago. But we see a lot of these patients in the vascular surgery world. We trained with the cardiovascular surgeons. So we saw this. We just saw it in a small part of what we did and didn't manage that aspect of it. So who gets heart disease? These are your classics: smokers, high blood pressure, overweight, diabetes, sedentary lifestyle, again, high cholesterol, and family history. Those are the big ones. Those are the big things we ask people when they come in with chest pain or a coronary event. Half of people who come in with de novo heart attacks, so first-time heart attacks, do not have one of these risk factors. 50% of people. So a thinking person would say, well, are these really the risk factors that we should be looking at? Or is there a lot more to the story that we're missing? Because this is a flip of a coin toss, flip of a coin. So these are the traditional ones. We screen for these. We obviously want people to stop smoking for a number of reasons. We want to get their blood pressure under control because of those autoimmune things we talked about. Obesity, diabetes go hand in hand for those metabolic issues. So again, there's a lot more to this. That this is just the tip of the iceberg. It's an iceberg we need to look at, but not the whole story. So where's the lie? So this is a clip from a heart healthy diet, and I will blow it up a little bit so you can see it. So this goes back to around the 1950s. And Ansel Keys is a name you should remember as really he's up there with Anthony Fauci in my book, because what he did is he was charged with looking at Does fat cause heart disease? Where is she? Does fat cause heart disease, or is it something else? Is it sugar? And so, where is that crazy cat? Huh. Oh, that's Koopy. Okay. I'm gonna say I can see him. So is it a high fat diet that is bad for our hearts, or is it sugar? And what they found out is that these high fat ketogenic diets did not have any correlation with disease. However, Ansel Keys came to the study or came to the forefront and said that his study showed that fat was bad. The sugar industry, the sugar lobby, then lobbied the FDA to say that calories were bad, fat is bad, and fat became the villain. So this is where we get the food triangle, the food pyramid, with fats at the top and carbs at the bottom, because the sugar lobby paid for that. They earned it. They paid. And so fat is bad. So we got into the non-fat, low-fat craze at that point in time. Sugars are okay because calories are the problem, not carbohydrates. So our entire dietary system flipped on its head in the 1950s. This is why we have the fattest, sickest generation we've ever had, because we've had bad advice for 75 years. So if you look at this again, this is just a carbon copy out of a heart healthy diet. And you can see here, what is at the top? Whole grains, sliced bread, crackers, cooked hot cereals. This is all the stuff I tell people to pretty much avoid. So the veggies we have no problems with. Fruits, there is a place for fruits, but not for people who have a metabolic issue. Fat-free milk, fat-free yogurt, low-fat cheeses. Again, now we know that if we're pulling fats out of foods, number one, we're modifying it. Number two, we're probably throwing carbs back in it to make up for the flavor and giving preservatives. When we're looking at protein, it's all lean cuts of protein. Poultry without the skin, fish, I have no problem with that, eggs. So we do start to see this, and this one makes me cringe. Soft tub margarine. Margarine was made as like a ball-bearing lubricant that they couldn't use in that way. I think that was Crisco actually, but along the same lines. So they made it yellow, called it margarine, and let you eat it. If you know anybody who has margarine in their fridge, go throw it away if you want to be their friend. And then look at these oils. There's been so much about seed oils in the news with Maha. This is on a heart healthy diet, and you wonder why people are so sick. So everything in this section I would absolutely disagree with, especially these processed trans fats, hydrogenated fats need to get out of our diet completely. We need to go back to animal meats and proteins and fats, and we need to stop being afraid of saturated fats as much as we are. And then sweets and added sugars, low fat ice cream, give me a break. So this is where that whole myth came in. Saturated fats are bad. A low fat diet is good. And 75 years later, they're still handing this garbage out to patients who are lost and overwhelmed and having coronary issues. So are statins ever helpful? So there is a place for statins in people with exceptionally high cholesterol. So that LDL above 170, that we're looking at a familial issue or a genetic issue. And I tell my patients, if your LDL is 200, you can eat cardboard and you're not going to bring that down. So, you probably are going to need something to help you bump that a little bit. And heterozygous is 1 copy genetically, homozygous is 2. You can see cholesterols in the 500 range up to 1,000 range in these patients. So these are the outliers. We do have to have a plan for them. I'm kind of talking about mainstream America. Post MI, there is a role for this, more so in men than women, but after a heart attack, that's a place for a statin, at least for a while. And then in cancers, there's actually an interesting role in cancer. There's a specific technique that you can utilize to deplete CoQ10 and deplete your antioxidants while you're trying to pop and put stress on the cancer cells. That's a very specific strategy that we're just incorporating and not for the everyday. So if we are going to give statins to people for cholesterol, not cancer, we're always going to give it with that CoQ10 so that we can mitigate the side effects of that. So what actually is our approach to cholesterol? Because this is something that we've taken under advisement. We make recommendations for patients every day on this. So number one, we look for metabolic syndrome, and we want to treat that and assess that. So we're doing a comprehensive lab. It's going to include things like fasting insulin, fasting glucose, A1C, inflammatory markers. We're doing more of a complete assessment, especially getting into hypothyroidism, looking at free T3. We're going to employ strategies to get that fasting insulin down, get those blood sugars down, using continuous glucose monitors to make sure someone's not spiking their blood sugar every day because they're going to eat spaghetti or Chinese food with lo mein noodles every day at noon. So this is more our approach. Generally, for most of our patients, we're going to advocate more of a low carb diet with intermittent fasting. And there's some variation on that from person to person, but that overall is a pretty decent strategy. Again, if we're finding hypothyroidism, hyperlipidemia is one of the most underrecognized symptoms of hypothyroidism. So I see a lot of people who have hypothyroid that's not correctly treated, that then get put on a statin, then they develop sore muscles and joints. They get diagnosed with rheumatoid arthritis. Now they're on rheumatoid medications and the high biologics, and now they're in chronic pain. You have this cycle that goes round and round and round, where if they would have just been treated properly for thyroid in the first place, you wouldn't be in that spiral and spin cycle. Lastly, I'm looking for detoxification of the liver. So I do have some patients, especially if hormones are off, if they're postmenopausal or postandropause, in that 50 to 60 range, and their hormones are really high and they're not taking them. I'm looking at the liver because the liver may not be processing things well and may need a little bit more support to do what it needs to do. So this is one of my favorite figures, and I'll blow it up here a little bit so you can see it. So you've got these predispositions, right? We have our genetics we can't change, our age we can't change, our lifestyle is really where we can move the needle on these things. So we're looking at insulin resistance, blood sugar, that high blood pressure. So many of my patients don't realize if you're spiking your blood sugar every day, your blood pressure is going to be high in response to that because that is a stress on those arteries. Obesity, central adiposity. So there's people with the beer bellies, that accumulate a little bit around the middle. We know that that pattern of obesity is much more dangerous than the pear-shaped figure. Different attributes to each of those. And then these are all of the different lipids we're looking at, and they all interplay. And that's one of the really overwhelming things. People ask me all the time, how come more people don't do functional and integrative medicine? Because when you start realizing that every decision you make is tied to so many different things, it becomes really quickly overwhelming. And you have to know, where am I going to start to unravel this? Because it's like a spider web. If I pull here, it's going to pull everything else over. But you have to get comfortable using that therapeutically. And then again, in the bottom, with COVID especially, we saw these acute phase reactions driving massive blood pressure shifts and blood pressure swings in people's, high and low blood pressure, and difficult to manage their inflammatory markers through the roof, things like fibrinogen. So we go after those as well. So again, assessing lipids and risk. So we do the advanced lipid panel, and I have one down here that I'll show you from one of our patients. So your basics, and I just ran the numbers. I think a basic cholesterol panel is $9, something like that. So the price of labs can be very manageable if you know where to get them and how to access them. So the other things we check: LDLP, or LDL particle number, LDL size. We check ApoB. So ApoB is the shell or the backbone of these LDL molecules. We collect and measure those. They usually go in sync with each other. We're looking at vascular inflammatory mediators like myeloperoxidase, lipoprotein PLA2, Lp(a) is an LDL with that special protein associated with it. You see it right here. Some of those are extremely high risk for cardiac issues and some are not. And then your general inflammatory markers. So here is the lab from one of our patients. So I will walk you through that here. And we're coming to the end, so questions are just around the corner. So you can see this top block here is the lipid panel. So triglycerides, this is from October of 2003 and this is May of 2004. So you're looking about a little over 6 months apart. So triglycerides were good to start with. This patient's diet was already optimal. The total cholesterol was 228. The HDL, the good cholesterol, this was a male patient. We like that over 50. So his was 72. So already I can tell you diet's pretty on point. I can tell you this is a thin male, probably 150, 160 pounds, 6 foot tall. LDL was 138. So I did not expect that when I met him originally. And then here's the real problem. So the LDL particle number. So his LDL, the weight is a little bit high, but when we look at the particle number, it was 2000. It was over double what it should be. So we should have around 1000 to 1100 particles. He has 2000. So those are, as you can see here, the small LDLs. His were actually more medium. So they were kind of on the spectrum of getting small and dysfunctional when we intervened on these. The HDL was looking really good. His LP little a, that genetic marker, was good. His ApoB, again, goes with this LDL and LDLP. It was up. His HSCRP was normal. Myeloperoxidase was good. His LPPLA2, again, this is that lipoprotein associated with vascular inflammation, a little bit up when we met him. And then this is 6 months later. You can see a lot of this red has either shifted to better red or yellow or green. So we normalized his cholesterol. We treated his LDL. And again, I think to get green on this, you have to be less than 100. He was at 100, so he didn't quite make the green swing there. But LDL particle number improved dramatically. LDL smalls reduced, LDL mediums reduced. So we're seeing his LDL go from small and dysfunctional to bigger and more optimal. The only thing we did for this patient is I treated his thyroid. So we did not use a statin. We weren't using berberine. We weren't using anything else. This is just correct treatment of hypothyroidism. And again, this was a thin person to start with, so it wasn't obvious that he had hypothyroidism because first of all, we think of that as a female problem, and we think of it as an overweight female problem, not an under normal to underweight male. So that was all we did for him. So we also use supplements to help. We try to figure out what the root cause is and what we need to do. Berberine is one of the big ones that we use. It's a PCSK9 inhibitor. This is the same class of drugs that like that Repatha is in. That's a $14,000 a year medication. Ours, our supplement's $50 a month or so that gets you berberine with other things. Omega-3 fatty acids or fish oils, we're doing 1 to 2 grams per day, especially if you try hypertriglyceridemia. Bergamot is not one I use as much. I haven't seen as much success with that, so I kind of shy away from bergamot, but if we don't have any other options, we will add that. Niacin's going to be great for LP little a, improving HDL, that good cholesterol, plant sterols, and again, CoQ10. We need to get that in there. So those are kind of the key supplements I'm thinking of. Red yeast rice isn't on the list. It's basically the plant version of a statin. You can get the same side effects with red yeast rice as you do a statin. So I don't use a ton of that, but I do have some patients who like it and do well with it. Stress is the silent killer. So stress, you guys know the people in your life that are just angry and ticked off all the time. They just run around and they're in a hypersympathetic state. Their blood pressure's high, they're angry, they're worked up all the time. This raises blood pressure, increases cortisol, increases stress, and it just creates quite a little spin that's not super helpful. So here's what that looks like. I'll blow that up a little bit. So, lack of control, burnout, relationship stress, you've got all of this kind of feeding into the system. You've got the circadian disruption, shift work, nights, jet lag, all of these things stress our bodies in ways that's really hard to mitigate. And they directly lead to an increase in those inflammatory markers, which feeds into, and these are again all interrelated, the blood sugar dysregulation. So those metabolic symptoms. There's a couple of things you can do on your own. Meditation. It's hard for me to, as a surgeon, to tell people like to go home and meditate, but I try to tell people take 5 minutes twice a day just to breathe and silence your mind, and that can do a lot for some people. And there are literally cardiology clinics that focus just on this piece and make a huge difference. So I don't want to underestimate the weight that it can play. Environmental stress is a huge thing as well. So, one of my clinics is located about 30 minutes from a battery factory, and we have patients who have heavy metal poisoning. And you've got somebody who's working at a factory, so they're exposed to lead and heavy metals. They're eating a crap diet, and they have heart disease, and they work all the time or night shift. It's like the trifecta of you couldn't get much worse. And what the factory does is they check the lead levels in their patients, and when they get really high, they switch them to a different department. So there's no plan to chelate or get rid of that. I've seen it firsthand. So it does happen. People who live near interstates where you have auto exhaust particle um, exposure to air particles is huge. Radiation. So if your chest is radiated, mediastinal radiation for things like lymphomas can cause premature heart disease. Diet, don't even touch caffeine. That's a free pass with me. Drink all the caffeine you want to, but about 40% of Americans do have a SNP or single nucleotide polymorphism that changes the way you metabolize caffeine, and it can raise your blood pressure for about 6 to 8 hours after drinking it. So if you're one of those people that gets real jacked up with caffeine, you may have that genetic SNP, and we can test for that. Um, Dietary choices, of course, the people who drive through the fast foods, and then internal environmental stresses. So if you have uncontrolled infections, you have gut issues leading to like leaky gut, and that the junk in your gut literally going out into your bloodstream all of the time. Um, One we don't talk about enough, and unresolved traumas or abuse. Huge issue that people bottle up and don't deal with, and I think we have an epidemic of that, unfortunately. So again, our approach, we want to look to optimize diet for our patients. There's very few people who walk in the door with a good diet or what they would consider a good diet. There are some, but always looking to improve upon that and use strategies for each individual patient that are going to work best. Reducing inflammation above and beyond is a top priority for us. Stress mitigation, again, normalizing the glucose and insulin. It's amazing the changes you can make in 7 to 14 days, just by changing the order of food that you eat, doing intermittent fasting, and using the approach that we recommend in the book Glucose Revolution. Changes people's lives. Making sure sleeping at night, awake during the day, trying to get that circadian rhythm back in zone. A couple of things that we underutilize that I would really like to do more: ozone therapies. So the major autohemotherapy actually stabilizes the plaque probably better than anything else we've talked about. So taking someone who's um, either just had a stent or have been given the option to do a coronary bypass grafts, and doing major autohemotherapy or your IV ozone treatments 2 or 3 times a week for a few months, and then backing them down off of that can really work here. As well as a sauna. It can be any kind of sauna. I'm next to my infrared sauna. Uh, It can be a steam sauna, a dry sauna. It doesn't matter. If you go in there about 20 to 30 minutes, 3 or 4 times a week, it actually lowers the mortality of coronary disease. And that could be the heat effect, it could be the stress effect, it could be a combination of all of those things. I will stop now. We have plenty of time for questions if anybody's interested. Um, Happy to clarify any of those points or go back to bring them up. So as you can see, there's a lot more to it than just take a statin and go home. Um, Cardiologists kind of have one lens on this that they look through, and we like to keep that a little more diverse. So thanks everybody for coming. I'll give another minute or two and we will wrap tonight, but I appreciate you being here. I don't see any questions in the chat or in the Q&A box. Katie, do we have any questions from online anywhere?
Not that I've been able to see so far.
Okay. One of the common questions that I do get, we recommend a lot of fenofibrate for hypertriglyceridemia. and for COVID related issues. And so those are not statins, those are a different class of medications. So, really, when we see elevated triglycerides, we're working on blood sugar, insulin, and diet more so. But high glucose and insulin diets can lead to elevated LDL secondarily. So, again, not just throwing a statin at it, but finding out what's the diet and what is the opportunity for optimization there. Very good. Well, if you have further questions, you can drop those on social media. We monitor those regularly. If you have questions about becoming a patient, um, let us know. Give us a call, 636-751-9440. You can email us hello@jamesclinic.com with your questions. We are an integrative concierge clinic, so we are more high touch. We are proactive. We like to help people prevent issues as opposed to reacting once they have them. So this is right up our alley, preventing heart disease and reducing risk as much as possible. So we appreciate you being here. Tune in next month. If you have feedback, you should have a post webinar survey. So if you have feedback on what you'd like to hear more about or what you might have questions about, fill that out because we do take that into account as we plan future episodes. And if you've missed our previous ones, check out our YouTube channel. It's James Clinic, and you can catch all of our previous public webinars. Thanks, everybody. Have a good night.